World Congress of Cardiometabolic Medicine 2019 in Mumbai as it's a peak now. To add on the another dimension in the armamentarium of WCCMM, we have none other than Dr. Thair Jumaily from UAE Fujairah Hospital. Pleased to meet you, Dr. Thair Jumaily. Let me introduce you, Dr. Jumaily. I'm sorry, my apologies for that. Dr. Jumaily, who is an interventional cardiologist by profession. He has been practicing about all the complex lesions of the intervention, including CTOs, bifurcating lesions, and so on and so forth. Yes. So we will hear from him in a very short while. So Dr. Jumaily, I would like to ask you brief questions. Tell me something more about your research and publications that you are going to do it, present as something tomorrow.
Yes, tomorrow in this last meeting, I will present about the cardiovascular complication of diabetes. As we know that diabetes is the most strong risk factor for the development of the cardiovascular complication. So tomorrow I will present the updates on how to prevent and to manage the complication of diabetes. If we can prevent it, better to prevent. If we cannot, at least we have to know some guidelines on these managements.
Right. So about the complex CTOs and bifurcating lesion, can you think of something new device and modalities that you can enlighten us? What is new in today's era in intervention cardiology?
Yes, actually, this is a very good question. Now we have a lot of devices that can help us to manage these complex complications, which is most commonly happen in the patient with diabetes, like the use of rotablator. Rotablator, as you know, it is a machine that causes debulking of the calcium or debulking of the lesion in the coronary artery. So by this machine, we introduce the wire, we cross the lesion, we introduce the machines that just break the calcium. So by this, we can easily dilate the coronary artery at the site of the stenosis, so make the procedures easily and to put the stent. So by time the result will be very good and the complication or later on sequences it will be reduced.
I guess I probably have to stop you here. I kind of agree and very humbly disagree with you on that because in my generation when I started doing the interventional cardiology or rather what we have been seeing that more and more complication with rotablators and cutting balloons and things like that. And the basic simple thing for that having is that when you do the rotablator and then the calcium segments, the fragments that get dislodged and give you a distal embolization. So you may clear the clot at the proximal end, but then you have a problem with the distal end. To combat that issue, I think that's the new thing that we have been using as the shock wave therapy. Yes. And I'm not sure how would you grade the shock wave. Of course, I agree with you that it is kind of the experimental trials. And at few places we have started been using it. But I must share with you my experiences that, I mean, I have like a huge respect for this. Partly because it's very simple, and anybody who does the intervention cardiology, who does the intervention work, who do the balloons and all, it's easy for them to do it. And the most importantly, you don't have something to cut the things. So the chances of dissection, distal embolization, and so on and so forth is very less. That said, we still encounter some of the complications, the chance of restenosis and all, they are still high. Have you ever encountered some kind of experiences? Would you like to enlighten us with the shock wave?
Yes, actually, as we know that the starting point in the managing of heavily calcified lesion is the development of the rotablator. But as you told very nicely that this machine is associated with a lot of complication. First of all, is the dissection, dislodgement of the debris to the distal part, sometimes even entrapment of the machine, which is a very difficult complication even to manage it.
Well, you have to be very, very skillful for that.
So that's why these machines need to be used in experienced in the people who
really need to have very tertiary care center
experience. Now, the last few years we started to hear about the use of the balloon, shockwave balloon. Shockwave balloon is a simple. So you cross the lesion by the wire, put a balloon. This balloon introducing or producing some shocks to break this calcium. So the complication is less. No need too much experience to do this procedure. Simply, it is just crossing the lesion with a balloon, inflating it, or sometimes even minimal inflation and giving shock to distract this calcium. Till now, it is a good option, safe option, and maybe by time it will become the first option for the managing of heavily calcified lesion. Maybe it beats more against the rotablator and even cutting balloon.
Well, I'm sure you probably will appreciate the difficulties that we see in our day-to-day practices, heavily calcified lesions. And how would you consider that is it good to leave them and treat them medically, or as opposed to be aggressive interventionists and then do anything or something, whatever need to be done to clear that block?
Yeah, this is it depends on case by case. Actually, all the cases of the very high calcium or calcified lesion. Sometimes if it is diffuse disease, small vessel, the patients have multiple risk factor, and you feel that doing the intervention for this lesion, it will produce more complication than benefit. It's better to aggressively control this patient by the medicine. However, if the patient is young, if the patient is continuously to have symptoms, and if you feel that these lesions can be treated without complications, it's better to tackle them by the intervention, to distract this calcium by whatever the machine, and to put stent or even drug-eluting balloon or any way of managing these lesions by the intervention. For me, I will be more aggressive in managing these patients by the intervention. So by time these patients have less symptoms, and even sometimes they may have improvement of even their ejection fraction if they have decrease in the ejection fraction because of these lesions.
So Dr. Jumaily, if may I ask you to walk us through about your recent publication, the research that you're going to talk to us to about the prevention is better than the cure.
Yeah. Now the prevention, now all the days now speaking about how to prevent the development of the complication, which is better than treating this complication. Now there are certain methods of how to prevent this complication. First of all, screening all the patients who have at risk of the development of complications.
So Dr. Jumaily, if I may ask you to walk us through about your recent talks that you're going to give us tomorrow about the prevention is better than cure. How would you like to summarize? Give us a key message about it.
Yes, now as we know, as a wisdom that prevention better than treatment. So now we have to know how to prevent the development of the complication, particularly in diabetic patients, because we know that diabetes is the most common risk factor for the development of a lot of complication in these people. So there are three lines of how to prevent this complication in this patient. First of all, to screen the patient at risk of developing this complication, and second of all, how to early treat them, so to control the disease at early stages better than the complication. And if complication happen, what to do and how to manage them by recent medicine. We have a lot of medicine now used for the treatment of the complication if it happened.
So if I ask you to conclude your talks, just a key home message for people,
Yes.
what would you like to tell them?
As an interventional cardiologist, always try to prevent the development of this complication. So if you are at risk, please visit your doctor. Try to manage the risk factor like diabetes, hypertension, and try to avoid anything that increase the risk of the development of coronary artery disease like smoking. And if it happened, don't worry, not the end of the life. Just go to your doctor, manage you, let them manage you by giving a new medicine to prevent the development of this complication.
So the crux of the talks that we are at the right platform of WCCMM to avoid all those complications and to start early and prevent the diseases. Thank you very much, Dr. Jumaily, for having us on the show.
Thank you.